soon as I ask for a volunteer, please do jump on right away. Same rules as prior. You know, I'm not going to be your examiner. You don't have to feel kind of shy or concerned about anything you want to say with me. It's fine. And it's better to volunteer before you're called, because you know that if you're called, then your name is now labeled on video. But if you volunteer, then no one will know what you're saying. So it might be a good idea to volunteer right away as soon as we put up a tracing. So my let me see here. Let's see if we can get this going here. I'm not going to actually talk about the slide at all, but I put it up as a reminder, these two slides, you know, to just think about everything that goes on in a single muscle cell that fires, just the most amazing physiology of anything you could imagine. I mean, just one of those pieces is and I think this is just the voltage gated sodium channel alone. And think of the number of channels. I mean, as many years as I've done this, as you know, I was at CMC in '84. As many years as I've done this, it has never failed to amaze me, the physiology of the human heart and the cell membrane. To me, absolute proof of intelligent design. I know people still want to claim it's there's other possible mechanisms, but for me, absolute proof of intelligent design. So I put that up just to say that. Now, I'm not going to talk about EP studies, but I am going to just give you kind of a basic concept here so you can understand what we think about when we think of where the level of block is within the heart. I'm sorry, there's someone who's got their mic on and they've got some background chat going on. If you could just mute yourselves, and that'll be good. And then quickly, when you need your questions asked, feel free to unmute. Thank you. I don't know, Nitin, if you can identify and turn off their mic, that'll be great. Thanks.
Sure, sir. Sure, sir. So your video is off.
Oh, you have no, oh, okay. Sorry, apologize. Okay. Is it on now?
Yeah, yes, sir.
Okay, good deal. All right. Yeah, so nothing much on the prior slides, just basically, you know, I just showed just the cardiac cell membrane and all of its channels, just the amazing physiology that is, and the voltage gated sodium channel, just one of those channels, which to me, again, mind blowing. A basic EP study, when we do this, what we do is we put wires up into the heart, and this is just like an EKG that's being played at a very fast speed. And instead of 25 millimeters per second, we played at 200 millimeters per second, just so that everything gets kind of stretched out. And when it stretches out, it kind of slows down time so that we can look at where timing of events are occurring. So if you could think of a P wave and a QRS complex, that's what that would look like if you're inside an EP study. And in an EP study, and I'm not going to dwell on this, but just to give you a basic idea, it records the atrial activity and the ventricular activity. So it's pretty easy. It's not that hard to figure this out. Oh, any squiggle that's under the QRS complex, that's ventricular activity. Any squiggle that's under the P wave is atrial activity. And look at this sharp little spike. That's actually the recording of the His bundle. It's a beautiful, amazing thing that you can actually record the His bundle, the insulated bundle of fibers between top and bottom. So when we talk of block above and below the His bundle, it's very important. So whenever there's block in the AV node, it's between the P wave onset, between that, and when it hits this His bundle. So somewhere in this area is block above the His, and block below the His is in this area, there's block. That means there's slowing of wiring between the His bundle and the ventricle is block below the His. And the worst type of block to have is block below the His. Typically, if you have block at the level of the AV node, that type of block, there's usually still an escape rhythm below the His. Please interrupt me right now if you have any question on that. but otherwise I'll keep going. If someone speaks up, I'll just stop. It won't bother me at all. And I'm not going to go on that one. So I told you that every week I'm going to give you one tracing. This time I'm going to give you two tracings that just came to me this week. Here's one that actually, this is my senior from a batch of 7980 who sent me this EKG on the weekend and said, hey, this guy who has this monitor is a 40-year-old pathologist, medical doctor, pathologist who works in this hospital and has been having some weird palpitations, some funny sensation. And now he's got this tracing, don't know if a pacemaker is needed or not. If someone want to just think about this for just a second and just give me a broad comments, you don't have to make any big analysis. It's just a single lead, 2-lead rhythm strip. You know, it's not like a full EKG. You will see these in your practices as well when you have telemetry recordings to look at. So do I have a volunteer to just look at it and just give me your big picture kind of idea of what you're seeing and any concern? It's a 40-year-old man and he just has this episode. And so the concern is he's got some family history. He's a bit nervous. He wants to know if he needs a pacemaker.
Usagre, would you like to comment on this?
This is a ECG showing two leads. It's this lead 1 and lead 2 probably. It is showing almost a sinus rhythm. There's P wave before most of the QRS complex, or there's one wave that is not followed by a QRS complex. The PR interval also looks normal, and the heart rate of the patient would be sinus.
Yeah.
It's a bradycardia also.
Right. It's a little bradycardic.
And there
Okay.
are deep S waves that are visible in the lead that is lead 1 that is in the below.
Okay, don't worry about that part because when you have a telemetry strip like this, these are filtered differently. So some parts of the T and the S wave and so on can look very different. So let's not worry about that part. Just focus on the rhythm. And you very nicely said it's sinus rhythm and there's one P wave not followed by a QRS. And you said, well, the PR intervals look okay. And that's what we're looking at. So what is your thought? What do you think's going on here? Is this indication, do you think we should be thinking pacemaker? Is this a physiological type of problem or is it some kind of disease? What are we dealing with here? Or what type
I'm
of
not sure whether it's a paced rhythm because I'm not seeing that line on top.
It's not a paced rhythm.
Yes.
I'm not trying to trick you. It's not a paced rhythm. It's just a normal, it's just an intrinsic rhythm. So the question is, what type of block is this? Is this a first degree heart block, second degree heart block, third degree heart block? If it's first or if it's second degree heart block, is it type 1 heart block or type 2 heart block?
This could be more towards a second degree type 2 heart block.
Yeah. So okay, fair enough. A good start there. So and I don't just to move along with how we're looking at this. That's exactly the question that was raised by the person who sent it. It was a cardiologist who just sent this along to me and said, hey, and he had some idea of what it was already, but he wanted confirmation. So there is some concern. Could this be a second degree type 2 block with this abrupt drop P wave in the middle of nowhere with what looked like normal PR intervals before and after it? So with this, you must always pay attention to what happens before and what happens to after the block beat to decide whether this is type 1 block or type 2 block. And here's what I'm talking about. Look at this PR interval. I'm going to see if, I don't think I can expand it out anymore. It's probably as big as it is. Can you guys picture that the PR interval is about 200 milliseconds? It starts about there and ends about there. So one big box is 200 milliseconds, okay? And if you come over here, very conveniently, this is right on that dark blue line. This PR interval is a hair less than 200 milliseconds. Do you see that? It's slightly shorter. It's probably about 20, 30, 40 milliseconds less, maybe one small box less. So slightly smaller PR interval here and slightly longer PR interval here. And so now any thoughts on that now? You want to stick with the type 2, or do you want to have any thoughts on it? Or
Type 1 could be possible. So like slowly increasing PR intervals followed by a missed beat.
good. So whenever you have a PR interval before the beat, so you have to kind of put a calipers. If you're doing this on paper, you would put a caliper there, caliper here. You know, by caliper, I mean, you know, just like a simple divider from a geometry set. You know, put your point there and your point there, measure that, measure this, and you'll see that this is definitely a hair smaller. There's another thing going on with this guy, is that look at this P to P interval here, and look at this P to P interval here. So this P to P interval definitely shorter, wouldn't you say, even without measuring? If you just look at it eyeball, you can see this one's wider and this one's narrower. So again, this suggests that this is a vagal phenomenon, consistent with type 1 or just simply AV nodal Wenckebach block, because there's a surge of vagal activity in this part of the tracing. And then there's resolution of that vagal activity, or more sympathetic activity here, more parasympathetic activity here. So basically you have vagal effect, just someone deep breathing at 7 o'clock in the morning. Maybe this guy was just waking up. So he's, you know, he's running a bit slower on this. As you know, this is respirophasic. So with just respiration, you can get slowing of P to P, and then with exhalation or expiration, as you breathe out, you're going to have shortening of the P to P interval, depending on, you know, how long your breath is. So just vagal effect of breathing. So this is just probably normal vagotonia in a young guy. So vagotonic effect, not an indication for pacemaker, not type 2 block, but you got to always, whenever you have a block beat, you have a PVC, you have something that you're trying to figure out in cardiology, you must always look, when you're looking at a rhythm strip or an EKG, always look at the beat before and the beat after, to see what, see if you can pick up any clues. So I thought that was a nice one just from this week's recordings. Okay, let's take another volunteer here on this one.
Janvi, would you like to take this?
So today we'll focus largely just on rhythms. So I don't want you to spend too much of time on the QRS complexes. You can, you know, you're welcome to broadly guess axis if you wish, but don't spend too much time on that and just kind of focus on the rhythms. So today we'll focus just all on rhythms, unless there's something very obvious and glaring you want to say, talk about.
I can see a P wave followed by a QRS complex in each of the beats, and the axis is probably to the left. So the PR complex is the PR interval is narrow. The
Okay,
It's a sinus tachycardia and with a smaller PR interval than normal, and
Could I ask which lead you're looking at the P waves?
I can't really see it very well in lead 2, so I was looking at the precordial leads, so V2, V3.
Okay,
And
good. Okay, fair enough.
and the P wave seems sort of merge into the R wave, like in V3, like the P wave is ending right as the R wave is starting. It's like there's maybe pre-excitation.
Yeah. Okay. Hey, you did really well with that. That was good. A good start off. So let me just tell you how I would look at this. So I agree with you. Axis is leftward. It's a tachycardic rate of some sort. I agree with you that there is some kind of P wave over here. Totally correct. Now, I also agree with you very much so that this P wave, there's something weird about it. And so whenever you see something a little odd, you have to kind of say, well, hold on, what's going on? What's the problem here? This P wave is right almost kissing this QRS complex over here. It's just stuck right next to it, stuck on it. And so if this is there, I showed you on a prior slide, you need time to make your way up, way down from the atrium to the ventricle. You have to pass through the AV node for that. And if this P wave has gotten into this ventricle, then either there's an accessory pathway or there's something else going on. So you very correctly raised the possibility, well, maybe it's pre-excitation, and maybe that's why this P wave looks like it's stuck on this here, and this is actually part of a delta wave. And that's a tough one on this tracing, I'll give you that. But when you look at all these complexes, the majority of the complexes have a pretty clean QRS with no delta wave. So then I think, oh, okay, then maybe this P wave didn't really cause this QRS. And in that case, then I start looking for, are there actually more than one P wave? And so then now you start comparing in different leads, and then you start thinking, well, hold on. These little things over here, could these all be P waves? Or is this part of the QRS complex and this the T wave? Are you guys able to see my pointer when it moves?
Yes, sir.
Okay, so so that would be my next question, right? Or that might be your next question. Is all of this the QRS complex, and is this the T wave? Is this the next P wave? Or is this P wave and is this P wave? So that's the issue you have to solve for yourself when you're seeing this tracing. Would you agree?
Yes, sir.
Yeah.
They
So
look very
now, right, so they look strange. So what you might be looking at here, then you have to raise the possibility, is this some kind of atrial tachycardia, atrial flutter? So the right way to sort that out is to put your calipers, or put your, take a divider, or you take the straight edge of a piece of paper, put one dot here on the edge of paper and one dot there, and measure that distance and see if it walks perfectly to that distance, walks perfectly to that distance, walks perfectly to that distance. And in fact, that's what you will find this to be. So all of these are P waves, P, 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 P. So, so now you can tell, okay, now we're dealing with a very sawtooth-like morphology. This looks like what do you think this is?
so Flutter with a 2:1 block.
Good, Flutter with 2:1 block. That means this P wave actually did not conduct to this QRS complex, like you very correctly said, it's too close to it. This one actually conducted here, and this one actually blocks. This next one conducts here, this one blocks. That's what's going on with the Flutter with 2:1 block. So there that is, and let me go to the next one. Let me see if I've got yeah. So that's what it would look like if you got a slower level of rate of conduction from top to bottom. This one seem more convincing. This one's fairly straightforward, right? We don't need to dwell on this. Very typical looking flutter waves, sawtooth voltage, typical for typical flutter. I think I put this up mainly to remind myself to talk about this, that there are two kinds of typical flutter. Even this type of flutter, which looks positive in 2-3 and AVF, 2-3 and AVF, is still typical flutter. It's just using that same circuit that goes just behind the tricuspid valve, but goes in the other direction. And this is what we call counterclockwise atrial flutter. And this is clockwise atrial flutter, just moving around the annulus, the tricuspid annulus, in the clockwise direction and causing this positive on the inferior leads. Whereas in the typical, this is what we see the majority of the time, typical flutter. In fact, I just saw it in a 37-year-old nurse that I just did a consult on just a few minutes ago, a little while ago. Thought I'd talk about just some broad overview of just the mechanisms to think about where P waves are and where QRS complexes are during different types of SVTs, and don't pay too much attention to everything at one shot. I'll just kind of walk you through this. So if you have one circuit in the atrium that keeps rotating, like something like a flutter, and then those beats make its way down. It could be just an atrial tachycardia, an automatic focus, and then you get a 1-to-1 beat from top to bottom. That would be an atrial tachycardia. The P wave could be coming from any spot in the heart. It could be just one spot firing here, or it could be reentry, as it is in atrial flutter. And then you get P to QRS. It may be 2 Ps for every QRS, or 3 Ps for every QRS, as we just saw, 3 to 4 or even 4 flutter waves for every QRS complex. The common arrhythmias that you will definitely encounter, this one you're going to encounter for sure, AV node reentry, where you have QRS complex and P wave occurring almost at the same time as the QRS complex, sometimes hiding within the QRS and sometimes just following the QRS complex. In WPW, you have a circuit which goes down the AV node and up the accessory pathway. Even though I'm kind of zipping through the slide, we'll definitely come back and refer to it more. So fear not, you don't have to absorb everything in one shot. But basically, you're going down the AV node and coming up the pathway, and that puts your P wave out a little bit further from your QRS complex. And we'll look at some of the examples that we have of some of these tracings. What are your thoughts on this tracing? Next volunteer, please.
Susan, would you like to take this?
Do we have a volunteer looking at it?
Susan, can you take this ECG? David?
Yes, sir.
You can again focus largely on the rhythm. You can make some general comments about QRS if there's anything striking, but otherwise don't worry about it. Just talk about rate and rhythm.
So So the rate on the CCG is irregular. When I look at the lead 2 rhythm strip at the bottom, the rate seems to be regular with um, not all P waves being conducted to a QRS complex.
Okay, you want to give me your kind of overall diagnosis? Just
So I cannot appreciate the progressive lengthening in the um, uh, interval between P and QRS, but it seems to me that some P waves are not conducted to the QRS complexes. Whether it's a second degree type 2.
okay. Let me. I'm going to take it from there. So you did say there's something going on here with what looked like atrial activity, the P waves, not all conducting to QRS complexes. Agree with that. But when you look at it overall, if you just kind of step back and look at it, how does the rhythm look? It's a little tachycardic. Is it regular or irregular? I believe you said irregular, right?
Irregular.
Irregular, right. So what are you thinking if it's irregularly irregular? What are the
Probably an atrial fibrillation, sir.
atrial fibrillation or atrial flutter? Those are the two possibilities, right? For irregularly irregular rhythms,
Yes.
or at least the common ones. And so the issue at hand is this atrial flutter or is this atrial fibrillation would be a reasonable question to ask. Especially suspicious because this often happens is that you have this kind of in V1, a very prominent P wave. And you think, wow, that kind of looks like a flutter wave, almost like these previous tracings that I showed you, right? A little bit of that kind of appearance, right? But,
Yes.
but when you look here, there's a bit of a difference because when you look in the other leads, you see some leads look almost isoelectric and some look kind of very coarse and erratic, very just not predictable. Some little bumps there and some flat lines over here. Sorry, back to that. So the clues here are when you have this kind of smushed baseline that looks almost flat in some areas, as well as P2P timing or what look like flutter waves that look not fixed in timing. I think you could tell if you look at this that some of them look a little bit closer together, some look a little bit further apart. If you had calipers with you, you'd be able to tell easier. You could see even here that there's some difference. The second thing is, the second clue is just if you're ever asked on an EKG, you're trying to decide is this flutter or fibrillation. Another useful clue is the P2P timing is typically more than 200 milliseconds in an atrial flutter, in a typical flutter. Let me show you that here. Do you see this? One big box, 200 milliseconds. That's because typical flutter cycle length is typically 220, 250 milliseconds. See that distance from there to there? Whereas when you have atrial fibrillation, it's even if you were to see something that looks like flutter waves, they're typically in the range of 170, 180 milliseconds. So they're less than one big box. And I would agree with you that you can't see the boxes very well, but you can see one cross mark here and one cross mark here. So that's about 200 milliseconds. And so you can see these are shorter than 200 milliseconds apart. So that's another clue there to say that, hey, this is probably atrial fibrillation. And the irregularly irregular part, here's a useful thing, trick to know, to decide. If you can find 3 intervals, R to R intervals in a row that are fixed, you are absolutely not dealing with atrial fibrillation. So if you can find 3 R to R intervals that are absolutely fixed, but the 3 should be consecutive. For instance, this R to this R, this QRS to this QRS, this QRS to this QRS. If those 3 intervals were perfectly fixed, this is not AFib. And look here as hard as you can, and I will challenge you, and if you find one, please bring me scan it in, and we'll discuss it at one of our, maybe our last session, if you have one, and unless you're in complete heart block with atrial fibrillation, you cannot have that. So do remember that too. That's an exception to the rule. In everything, there's an exception. You can have complete heart block and atrial fibrillation. And in that case, obviously, you'll have fixed intervals because you'll have a junctional escape rhythm going at a certain interval. And then the atrial part is just staying in atrial fibrillation, as you would have over here. So you see here, if you have a junctional rhythm and you have atrial fibrillation going on up here, you can have a fixed rate as well as AFib. You can see that with digitalis toxicity sometimes. And you guys will surely probably see digitoxic rhythms in your careers. So you should know that. Or that'd be useful, rather, let me say. Any questions on that one, or I will, if not, I'll go to the next. Yeah, okay. I have a volunteer there. Looks like it's a 34-year-old. I guess the machine has read it as SVT. So you don't have to work too hard. You can tell me what you think, if you agree or don't agree. So don't always rely on what the machine says. I'm not asking you to change the diagnosis, but I'm just saying never believe what the machine reads out. So you have to look for yourself.
Prabhuram, would you like to take this ECG?
Good morning, sir.
Morning.
This ECG shows narrow complex tachycardia. So
Good.
So we have
Do you happen to know the broad categories of narrow complex tachycardia? Do you, in terms of short RP or long RP, have you heard those terms? Do you use that, or if you have any terms that you want to throw at it, you can. If not, I'll walk us through it.
no, sir.
Okay. Yeah, no problem. No problem. So I completely agree with you. It's an SVT. I really like that you said it's a narrow complex tachycardia, and it's kind of strikingly narrow. Huh? The QRS complex is narrow. Why is it so narrow? That's because it's a 34-year-old. And so they have a very skinny QRS complex, almost like a pediatric EKG, even though, and that's probably why the voltage is so prominent as well. So narrow QRS complex. Now, whenever I look at a narrow, an SVT, I'm always trying to see where are the P waves, because that kind of helps me figure out what type of SVT it is. And it's really hard to tell. I mean, sometimes there's a little something down here and I can't tell. There's maybe a little bump over here. Just tough to tell. I can't barely see any P waves. Just see QRS complexes and ST segments, and nothing there that's very reliable. So this is the same person in sinus rhythm after conversion. And now, so what's helpful in these is to actually compare, oh, okay, this person's P wave is a pretty good sized, solid looking P wave, about that big. And you can see it's pretty clean in V1, their P wave. So let's see if now we can go back and see during SVT, if you can spot the P wave. Hold on. All right. So I still can't see it. I really cannot. The only thing to look then is to say, then what type is this? It's a short RP or a long RP tachycardia, and what does that mean? Let's go to this slide here. If this is the normal P-QRS complex, when you have a short RP tachycardia with no, this is essentially functionally a no RP tachycardia. The P wave is happening at the same time as the QRS. If you can picture that reentry, the reentry is occurring. Let's see if I have a tracing here. So if you have reentry at the level of the AV node, this is what's happening in this patient. The reentry is happening at the level of the AV node. And so every time an impulse zips around the AV node, one impulse, the impulse breaks away and goes to the ventricle and goes to the atrium at the same time. So that's why you get P wave. If you were to record the right atrial signal, it'll happen at the same time as the QRS complex. So P and QRS happen at the same time. So you see no visible P wave, just QRS complexes. So that could either be a junctional tachycardia or typical AV-nRT. And there's junctional tachycardias are very specific. In adult population, they're quite rare unless patients are sick from something post-operative junctional and so on. So the typical SVT that you are going to encounter, which would be on your wards or in the casualty, if people come in with an SVT, is going to be this type of SVT. AV-nRT would be one of the common ones, where P wave and QRS happen at the same time. And because they happen at the same time, you cannot see the P wave. You just see only QRS complex. Does that make sense? The reentries at the AV node activates atrium and ventricle at the same time, and that's why you cannot see the P wave. Did that make sense? Okay. So reentries at the node, you cannot see the P wave is at the same time as the QRS. There are some tiny clues which are going to be difficult, but probably the P wave is right here towards the tail end of the QRS complex. How do we know? Look at how the QRS and the ST segment look in during tachycardia, and look at it when they're in SVT. You can see a small notch over there, like a little notch at the end of the QRS complex, and that notch essentially disappears during SVT because the P wave is hiding in there and it's obscuring that notch. But I don't expect you to pick that up. I'm just saying that no obvious, easy to discern P waves. There's some little squiggles here somewhere that I might think, maybe a P wave, but it's not very consistent, so I'm not going to call it. And I'll say this is what we call a short RP tachycardia, either a short RP tachycardia or a no RP tachycardia. AV-nRT is the most likely diagnosis. If you start seeing the P wave further and further out, that means that you probably have conduction going down one pathway and coming back up another, like a WPW or down the AV node and up an accessory pathway. So the longer you get, then more likely that this is not just a typical AV node reentry. So these are called no Rp tachycardias or short Rp tachycardia, so these two together, and long Rp tachycardia. So I want to spend just another 30 seconds on this. Long Rp tachycardias, what could they be? They can be atrial tachycardias or atypical AV node reentry or orthodromic reentry. Orthodromic reentry is just basically a fancy word for saying conduction is going down the AV node and coming up an accessory pathway. So these are the differential diagnoses for long RP SVT. Short RP tachycardia can be either atrial tachycardia or could also be WPW, where you're going down the node and up an accessory pathway. So whenever you see the P wave very clearly in the ST segment or somewhere between here and here, you see the P wave, then you should be suspicious that you're dealing with an accessory pathway. Because remember, AV nodal tachycardia, AV NRT, there's no accessory pathway. It's just dual AV nodal physiology. It's like an AV node that just has two little pathways within it. So that's a helpful thing to differentiate, because clinically you might be thinking a little bit differently about WPW or pre-excitation. You know, you'll have to be careful about which drugs you use. You may be more concerned about fixing their problem than leaving them long-term on medication. Let's see. Let me see if you want to do this one. Okay, we can do this one. Don't get stuck on the QRS complexes. They're a little bit odd on this tracing. Just eyeball the rhythm and see if you can make any sense of it and see what you want to call it. Let's say, do you want to call it a short Rp tachycardia or a long Rp tachycardia? That would be a good starting place. It's definitely tachycardic, if you would all agree. And maybe whoever volunteers, just take a look at it and see what you think. Short Rp or long Rp tachycardia.
Praneeth, would you like to take this?
Guys, don't take it too. You don't have to think too hard about it. Just kind of see if you can identify the P wave, and then decide if it's short or long. By short, I mean R to P. If it's close to the QRS complex, it's going to be short. If it gets out further from the QRS, and remember, it's a tachycardia, so we're talking about R to P. That means from the R wave to the next P wave, is it short or is it long? And then tell me which lead you're going to look at for that you've been looking at.
Yes, Janvi, go ahead.
Sir, I was looking at, I see two positive deflections after the QRS in V6. I thought the latter one might be the P wave, making the long RP.
Hey, very good. Excellent. Excellent. Very good. Yeah, I do agree. There's two bumps over there. And then what do you make of these two positive deflections? I mean, you know, it's hard to tell. Is there another P wave hiding here? I just gave you one a few tracings ago where I kind of caught people off guard and said, hey, could this be 2 to 1? What about that? What do you think? Could this be 2 to 1? Could this actually be the P wave? I'm not going to mislead you anymore. I agree with what you said. I do think that is the P wave there. I don't know if you were looking at V5 and V6, but there's a nice clean P wave there. Also in lead 2, you can see a nice P wave just in front of the QRS. But if you were just looking at this, based on that, you know, that tracing I gave you a few ago with 2 to 1 atrial flutter, how would you tell between this one and that is this flutter or not? I'll tell you what you're going to have to do, and you will have to do this yourselves on an EKG and take a caliper, which again is just you know, geometry divider with points on it, metal points on it, so you can measure clearly. If it's a P wave, if this is a 2 to 1 flutter, then this is going to need to be a P wave. This is going to need to be a P wave. This should be a P wave. This should be a P wave. And if you make a measurement, you're actually going to find out that this P to P is shorter and this P to P is longer, or this little deflection to this deflection is shorter, and this one is longer, the timing from here to here. And so that'll confirm for you that this is, in fact, this thing is not a P wave. So it has to march out perfectly for it to be a 2 to 1 block, or for it to be 2 to 1 P wave. Does that make sense? Was that clear to the person who just read that as to why I agree with you? And I'm not saying that this is 2-to-1, but you must watch out for these, that there isn't another P wave hiding in here. Is that clear?
Yes, sir.
Okay. So long Rp tachycardia from QRS to P wave, pretty good distance here. That means it's in the second half of the, if you can divide that distance from R to R into 2 portions, you draw a line over here. This P wave is falling in the second part of that, correct? So it's a long Rp tachycardia. If the P wave was falling here, we'll say it's a short Rp tachycardia. So now the other thing is, then what is this? Is this an accessory pathway or is it an atrial tachycardia? And I think it's not unreasonable to just think about that for just a moment. The P wave in lead 2 and lead 3 and lead AVF, positive or negative?
It's positive.
Positive. So then if you think about this, if you think about this mechanism here, if you have conduction coming down the AV node and going up an accessory pathway, then typically the P wave in 2-3 AVF will be negative, because you can picture the atrium is being depolarized from the lower part of the atrium, because the lower part of the atrium is attached to the AV ring, to the valves, correct? The lower part of the atrium. So accessory pathways, they happen where? They happen right at the level of the valve. They connect atrial muscle to ventricular muscle at the level of the valve. And so if you had impulse coming up an accessory pathway, then it would activate the atrium from low to high. That means it'll be inverted P wave in leads 2, 3, and AVF, just like they've tried to show you in the cartoon here. But if you have a P wave that's positive in 2, 3, and AVF, then you can be fairly confident that this atrium was activated from high to low. So suggesting that this is just an atrial tachycardia. Does that make sense?
Yes, sir.
Okay. So typically in WPW, you're going to find, or accessory pathway mediated. If it does show, there are some exceptions to all that. Of course, you can find some exceptions. I can quote some obscure exceptions to every rule. But in general, if you have a positive P wave, if it's very obviously positive in 2, 3, and AVF, most likely you're dealing with atrial tachycardia. And you can take that to the bank with most of the tachy tracings that you're going to encounter in your practice. And okay, let's have. Oh, I don't know that this shows very well. I'm sorry. I apologize for that. Let me see if I can. Maybe I should exit screen share and go to this. Let me see if I can pull it up a little bit so that it's. You can still see my screen, right? I just went to the view with where I can show the bottom of this. Is this better now? Lead 2, you can see the whole lead 2.
Yes, yes, sir.
Okay. Can I get a taker on this? Again, just focus on the rhythm. Don't worry about the QRS and the axis and all of that. Just the rhythm. What kind of rhythm do we have here?
Reba, can you take this?
Maybe let me make this, take this in a different direction. Look at this, the machine has read this, atrial fibrillation with RVR, voltage for LVH. Do you agree with the AFib with RVR? With rapid response? or any concerns?
So it can't be AF because there are P waves visible.
Oh, well done, well done. Very good. So cannot be AFib because they're very distinct P waves. You see a nice clear P wave on each of those, just in front of every QRS complex. But the rhythm is, wouldn't you say it is irregularly irregular? You agree?
Yes, sir.
Yeah, irregularly irregular rhythm. So what is this rhythm then? What do we make of
So
this?
multifocal atrial tachycardia.
Very good, excellent. So at least how many different types? Let's say that's one looking P wave like that. This one looks a little different. This one looks a little flatter here. So at least 3 different types of P waves, irregularly irregular rhythm, multifocal atrial tachycardia in your whichever ward you keep all your COPD patients with common arrhythmia with lung disease. Okay, good, excellent, well done, well done. All right. Okay, we need a taker on this. Anything that I show you is just a tracing that someone gave me and said, what do you think this is? Or they called and said, do you think we should do X, Y, or Z? So I really don't need to look far to find these things. So that means one of the other cardiologists called and said what to do with this. So this was a guy on telemetry, and then they said, you know, what are we dealing with here? Should we be thinking about ICD and what's going on? Any thoughts? Yeah, do we have a volunteer?
Maria, can you take this?
So there are P waves which are followed by QRS, but the QRS is a broad complex QRS.
Yeah. So, okay, yeah. So that's the same concern that was raised by my colleague and said, hey, this is looks like VT. What's going on over here? And so, you know, you must be very careful with these single lead rhythm strips. You do have patients on telemetry, right? I mean, you have some patients on telemetry units. I don't know if that's only within the ICU that you would record telemetry, but whatever it is, you're definitely going to face this problem of looking at telemetry strips and trying to figure out what to do with these people when you see these types of strips. So whenever I see this, I'm always looking, you know, does this make sense? Is there anything I can see walking through it? It looks odd. It looks like maybe a VT, maybe not. And then I'm not quite sure what this thing is. There's a little spike in the middle of it. I can't really tell what it is. So whenever you see even one little sharp isolated spike like that, that looks a little bit different from everything, you should try to see, does that measure with anything else? And here I'm going to do this for you. And I'm going to say that if I take, here's another one of those I see. If I measure from that to that, I'm going to say that there's another one right there, in there probably somewhere, another one right there, another one right there, another one right there. By right here, what I mean is it's imaginary. It's there, but it's hidden by the QRS complex, whereas the next one appears right here. Now, can you tell what that rhythm is? And this one is, it's actually, this is not like one put just to fool people and make them feel bad, but it's definitely artifact, because this comes to me often. So what you must do is look at the tele and kind of see what the basic sinus cycle length was before and after the tracing, and take that in your calipers. And then when you walk it, you'll see, okay, that's that, that is that. There must have been something in there. There must have been something there. There must have been something here. And there's the next QRS showing itself. So this is just artifact. This is lead movement on a telemetry with the cable just moving. So patients brushing their teeth or just moving their hand or whatever it is. But this is one to really watch out for. You will definitely see this at some point, and these kinds of things cause a lot of excitement when they happen, and sometimes unnecessary heartache for the patient. Maybe we might be out of time. I don't know. Do you have time to do one more, or do you have another lecture to go to, or what's your status?
We have time, sir.
Okay, you don't have to be nice to me. I mean, I'm okay to stop if you want to stop, but if you want to go for another 5 minutes or so, we can do it. I don't mind.
Yes, sir. We can take 5 to 10 minutes more.
Okay. All right. So let's get a volunteer on this one. Again, largely looking just at rhythm. And I apologize. I told you that I'll show you stuff just from this week every time. And this is a patient that I worked on last week. These are the recordings of lead 1, 2, 3, AVR, AVL, AVF, and then of course the V leads are labeled. But this is lead 1, 2, 3 over here. Excuse me. And this is at just to focus just on the rhythm and tell me what you think.
Prabhu, can you take this one?
Sir, it looks like a regular rhythm, sir.
Yes. It look tachycardic to you? It looks tachycardic, right? You don't have any markings on it, so I know it's unfair to ask that, but it's tachycardic.
Yes,
It's
sir.
played at a regular EKG sweep speed. So this may be, let's say, 180 beats a minute. So, and then you remember we were thinking about different types of tachycardia. Are they narrow? What are the broad categories? Narrow complex or wide complex tachycardia? This is a regular plain EKG. So do you think it largely looks narrow or wide?
Looks like narrow, sir.
Agree. So narrow complex tachycardia, very good. And then whenever we look at narrow complex tachycardia, it's always helpful to think a little bit about, do you see a P wave or is there no P wave? If you see a P wave, if you don't see a P wave, then there's one diagnosis for it, 1 or 2 diagnoses. If you see a P wave, then you have to tell me, is it a short RP or a long RP tachycardia, just for the broad categories.
Yes, sir.
So do we see a P wave here?
P waves are present, sir.
Okay, which lead are you looking at?
In lead 1.
Okay.
Looks
All
like.
Right. And I do agree with you. It's definitely a P wave there too, but it's kind of small. I always train my eyes to go straight look at lead V1 every time I'm looking for a P wave. I always go look in V1 for a P wave. Now, can you see it? Okay, so this is QRS complex here.
Yes,
okay.
sir.
And this whole thing is actually the ST segment, and this is the T wave, and then it's coming down, QRS, ST segment, T wave, coming down. So now you see the P wave? You see that? Right
Yes.
there. So it's a nice clean P wave there. And then when you walk that up, see there, it's kind of negative there in lead AVF. And it's a little isoelectric in 2. It's not very clear. It's probably negative, sorry, in 1. It's negative in lead 2, negative in 3. See, it's negative there, and negative in AVF. So this is a short RP tachycardia or a long RP tachycardia?
This is a short RP tachycardia.
Very good. Because if you divide the timing between the QRS and QRS R to R, you divide it into 2 parts. Anything when it falls in the first part, that's short RP tachycardia. Falls in the second part, it's long RP. So short RP tachycardia possible contenders are, let's try to keep it simple here. Short Rp tachycardias could be orthodromic reentry. That means using an accessory pathway. Let me see if I can show you my little cartoon. Orthodromic SVT using an accessory pathway, or AV node reentry. It's usually a slightly atypical type of AV node reentry, or it could be atrial tachycardia. Those are the three differentials. Of these three, you're trying to decide, is this related to accessory pathway or is this an atrial tachycardia? Let's set this one aside for now. And the way to decide that, remember I said that if it's a positive P wave in the inferior lead, more likely to be an atrial tachycardia. If it's a negative P wave, like this person has in the inferior lead, AVF, lead 2 and 3 are all negative. So this is more likely accessory pathway mediated. That means this person's rhythm was going down the AV node, coming up the accessory pathway. And why do I say that? It's because when the atrium is activated from low to high, by low, I mean away from the feet. So 2, 3 AVF are negative. P wave is negative in 2, 3 and AVF. Then we know that this is low to high activation of the atrium. And that's that's most likely pathway mediated. But I think it's really more than enough to say on the general medicine side would be to say that, hey, this looks like a narrow complex tachycardia. It's a short Rp tachycardia. This could be anything. It could be AVNRT. It could be accessory pathway. Accessory pathways are all WPW, or it could even be an atrial tachycardia. I think if you were, you got that far, I think you're doing just fine. Same patient. So now the issue is obvious, correct? Yeah. The same person didn't make their comment, but you'd agree with me, it's a nice, very obvious pre-excitation. And as I promised you, this was just from this week's, this was, so you'll have to, you can see the intervention that was performed between this and this EKG. This was at 7:30 in the morning, and a little later in the morning, you know, their pathway is gone. So this was someone we ablated this week. And I think, the reason I put this in here is, look at this, because this you may see also, because I think you guys do see more WPW than even our general medicine people here might see, because a lot of it gets taken care of with pediatric cardiology here. But you see, when you're in sinus rhythm, the delta wave can look kind of small or small like that. In this person, it's quite obvious. But once the rate gets fast, in this person, I'm actually pacing, but let's just say they had an atrial tachycardia, then you're going to get a wide complex, almost looks like a VT beat, VT complex. And it's just full pre-excitation, because now everything is going down the accessory pathway with very little down the AV node. Whereas during sinus rhythm, only a little bit of the activity is going down the AV, down the accessory pathway, and the rest of it is going down the AV node. So each beat is a fusion between activation coming down the pathway and down the AV node. Whereas when you go fast in the atrium, like an atrial tach or an atrial fib, then you're going to have a full pre-excitation or very wide complex. Let's see if we have another one. Okay, here's another rhythm strip that's worth looking at. And I'm just kind of getting our feet wet about, you know, some of these, the next specific group of tachycardias that we'll go to in the last session next week. But can I get a comment on that, on this tracing?
Abhinav, can you take this?
The rhythm looks sinus.
Sinus over here, I'd agree with that, but something going on here, right? So what's going on here? And here, this is another one where I got called to say what's happening. This patient is, frankly, the call was from another cardiologist who said that this patient's having VT, is operated for, come in for knee surgery and is having VT. So that's the diagnosis made by someone. So you have to tell me what you think.
It looks like a non-sustained VT, like a chain of VPCs together.
Right, right. Yeah, so that's what he thought too. So we're looking at it, and that's definitely, and you remember what I told you, whenever you look at rhythm strips, always look at what happens before and what happens after. Okay, so now can you tell me, look at what happens after and what happens before. Look at what's the before and after. Any rhythm strip, anytime anyone gives you a rhythm strip and says, hey, there's something funny going on here, always try to get, okay, what happened just to the left of it? What just happened to the right of it? Any thoughts now?
Could be an ischemic process is develop new onset ST depression and T inversions in the same lead. Following that.
Okay. So yeah, I'll talk about that. That's a nice observation, and I'll talk about that here in a second. But that's really not where I was going. Look at this here now. So this is a wide complex beat. So we're trying to distinguish, is this SVT or VT? What happens here? Look at this right here. Almost exactly the same as all of this, right?
Yes.
So the tachycardia is continuing, and now the tachycardia is narrow complex. So what was this? Is this a VT? No. This was just a bundle branch block that then resolved. And so you have a narrow, so it's basically SVT with bundle branch block. And it just happened to be that you have the patient shows us a left bundle when they are at the initial stage of the tachycardia. And then it goes on to just the left bundle then resolves, and you have narrow complexes here. So this is definitely SVT with aberrancy, or SVT with bundle branch block is what this is, this portion here. Because this is the issue that was at hand. This is the issue that I was called about and said, you know, something needs to be done. This patient looks like they're having VT. But when you look at this, you can say, okay, the tachycardia continued, wide complex became narrow. That doesn't happen with VT. That can only happen with a supraventricular tachycardia. So this same tachycardia over here, when it was conducting down from atrium to ventricle, was slow in the left bundle. And when it slows in the left bundle, then you get left bundle branch block along with an SVT. So SVT with bundle or SVT with aberrancy, right? And okay, and then what about this? So post tachycardia, any type of tachycardia, post tachycardia, you can get T wave changes, just non-specific T wave changes. You can get it even after a fast run of sinus tach in some patients. After a little SVT, you can get a little non-specific T wave change. So that's probably all that it is. And when you're looking at one lead rhythm strips, be careful about calling the ST depression. It'll always kind of overread it or over exaggerate it. It's just to do with the filters in these one lead telemetry units. So when you have a tele unit like your ICU and so on, and you have I have a one lead rhythm strip, and suddenly the STs look down, and no need to panic. I mean, it's usually just a artifact. And if you get a good 12 lead, you'll be able to tell whether it truly is or not. Okay, well, I don't want to keep you guys anymore. I will end right there. And I think I just have one last one to show you, then I can add that on to next week's. So that should be fine. Any questions, folks?
So regarding the RP interval, for long RP interval, you said atypical AVNR. Is it antidromic, same as the atypical? Or for long?
So antidromic tachycardia is basically anything that's coming down the accessory pathway and going up the AV node or largely just coming down the accessory pathway. For instance, this tracing here, if I told you this happened to be that I was just pacing, but if I wasn't pacing and this was a tachycardia, this would be an antidromic tachycardia, where you're coming down the accessory pathway and up the AV node. How do I know I'm coming down the accessory pathway? It's a wide complex and almost looks like a VT. We know that I'm not coming down through the normal conduction system to the ventricle. And then there's other criteria to distinguish between SVT with bundle branch block and VT, and we're going to do that in the last session next week to distinguish different types of wide complex tachycardia. But if your question is on my little cartoon on this is actually drawn by John Miller, one of my attendings in Indiana. So I love his trace, always so clear. So short RP or long RP. So long RP tachycardias could be atrial tachycardia where this P wave is conducting to this QRS complex. Just like one of your colleagues read on this, let me see if I have one trace. Here, this one. See, this is a long RP with this P wave conducting to this QRS complex. This P goes to this QRS. That is exactly this form of tachycardia, atrial tachycardia. And obviously, if it's an atrial tach that comes from low in the atrium, it may be inverted in 2/3 AVF. Atypical AVNRT, it's very is a little bit uncommon. Only 20% of AVNRTs are that form, and that can also cause a long RP tachycardia. And for an accessory pathway or WPW to cause this long RP tachycardia, it has to be an unusual type. These are called PJRT, or permanent form of junctional reciprocating tachycardia. PJRT will give you this long RP tachycardia. That's like for your, some examiner shows up with some obscure need to ask obscure questions, they can ask you that. But so long RP, unusual types of accessory pathways that take a long time to conduct from ventricle to atrium can cause a long RP tachycardia. Most accessory pathways, you go down the AV node and you quickly come up the accessory pathway, and the P wave will usually be in the initial part of the ST segment. So the number one diagnosis for short RP tachycardia is orthodromic SVT. That means SVT using an accessory pathway down the node and up the pathway. Accessory pathway. No P wave, the number one diagnosis will be AVNRT. No P wave. Junctional tach, of course, and because you guys look after kids a lot too, you can see in junctional tach in kids. Long RP tachycardia, first diagnosis should always be atrial tachycardia. Did that help?
Yes, sir.
Okay. Any other questions, folks? I'm happy to click on any of the other tracings if any of them were not clear. We've got them all here. So if you need to, I can do that for a minute or two more.
If you have any more doubts, you can ask now. There are none, we can wind up the session, sir. Sir, thank you so much for taking your time, sir, for teaching us ECG basics. Next session, can we plan on next Tuesday, same time, sir?
Yes, actually, that'll be fine. And I'm going to, I know so far I haven't been kind of announcing what I've been doing today. I focused on all SVTs. Maybe next time we'll focus on, we looked at narrow complex tachycardias largely today. Atrial tachycardia, atrial fibrillation, atrial flutter, AVNRT, and WPW or orthodromic SVT. Next week, we will look at all wide complex tachycardias. So if you wish to, you can come prepared, or you can just come and enjoy. It's like bring your kind of like a vade and coffee or something in the morning and be listening without putting any stress into it. So I shall see you next week.
Sure, sir. Thank you so much.
Thank you. Good night.